I'm Dr. Rafael Bach. I'm a medical oncology consultant here at Clatterbridge Cancer Center. My background goes from medical training at Malaga, Spain. After that, I had my specialist training in Barcelona. And I had a visiting fellowship here at Clatterbridge before joining as a consultant. Currently, I'm working as a consultant medical oncologist. I'm specializing in skin cancer, melanoma, and immunotherapy. And I am also part of the immunotherapy toxicity team, where we manage toxicities from immunotherapy treatments, and we focus on improving patient safety, all the immunotherapy-related pathways. Sometimes we have easier access to some treatments that are otherwise restricted in the NHS practice. That's, for example, we sometimes have more flexibility for radiotherapy treatments, for example, like stereotactic radiosurgery. Also, some brachytherapy for skin cancer can be offered by my radiotherapy colleagues. Regarding systemic treatments for melanoma, we have in the private clinic, we do have access to immunotherapy, which is the main treatment for melanoma that makes the immune system attack and detect the cancer in a way. So we do have access to these treatments as well, and sometimes we have more flexibility with this treatment, sometimes to re-challenge and to offer other treatment in second line that sometimes are restricted or not available in the NHS practice. For non-melanoma skin cancer, we can offer adjuvant immunotherapy for high-risk squamous cell carcinoma after surgery and radiotherapy. This is a treatment that is licensed and approved by for example, the European Medical Agency, but it's not yet available in the NHS. It's something that we can offer in the private practice for selected patients. For other non-melanoma skin cancer, like basal cell carcinoma, we can also offer systemic treatment that are, unfortunately, so it's one of those treatments that are not routinely available in the NHS. Here in the private practice, we can offer that for a broader population. Currently, that's done by our dermatologist colleagues in other centers around the region. If after they are diagnosed, if they require treatment, they get referred to us, where we manage systemic treatments like immunotherapy, targeted therapy, and also radiotherapy. So patients usually get a diagnosis from their dermatologist or private dermatologist or public dermatology. After that, they can be referred to us. Mm-hmm. We always review the cases, and we work alongside with the regional MDT, where we can discuss the cases and make a plan even for the NHS or for the private patients. Both would be the same. We make a treatment plan to see what's the best approach for them. If it is radiotherapy or systemic treatment, we can offer that here at Clatterbridge private clinic, either Liverpool or Wirral. If they require, for example, surgery, we would refer these patients to our other colleagues that work in other centers in the region. Usually in the private practice, we sometimes have more flexibility to prescribe these treatments. Sometimes to re-challenge with the treatment if it didn't work initially or for a second lines. For some treatments like adjuvant immunotherapy for squamous cell carcinoma, is a treatment that has been recently approved by the European Medical Association and the American Association. However, it's not yet approved in the NHS. However, it is licensed, and we are allowed to treat those patients if they are, after discussing with the MDT, and if they are eligible for the treatment, they could be treated. In a similar way, patients in the private clinic, they can have easier access to other treatments like radiotherapy or stereotactic radiotherapy that sometimes is more restricted in the NHS practice. Usually it can be a mole that is just not looking right, or is growing, is bleeding, is not a typical mole, or sometimes it's just a skin lesion that is causing discomfort. So usually it's always good to have this checked, and also have dermatology screens. If they turn out to be a malignant skin cancer, it's very recommendable to approach them as early as possible, have surgery or other treatments if necessary. So currently it's a service that is growing. There are some patients that particularly having radiotherapy, and recently we have started offering systemic treatments as well as immunotherapy and targeted therapy. And hopefully we will be able to grow the team and have more colleagues. Immunotherapy has been one of the most important developments in cancer therapy. So unlike chemotherapy that attacks the rapidly dividing cells, with immunotherapy we aim to stimulate the immune system so it can attack and detect any cancer cells. So the cancer cells sometimes use a type of brakes to evade the immune system. With this immunotherapy, we target those brakes, we release those brakes, so we activate again the immune system, and so it can do what it was designed to do. And unlike with chemotherapy, we can sometimes see long-term and long-lasting remissions that can last many years. For squamous cell carcinoma, we know that patients with high after a surgery, those patients that had a high risk, like nodal involvement or perineural involvement, they are on a higher risk of having this cancer relapse. And we know that with immunotherapy, we can reduce that risk significantly. Yes, so the side effects from immunotherapy are completely different to the ones that you could expect with chemotherapy. So most of the patients do tolerate immunotherapy well, and we can say that they have less day-to-day side effects. However, when side effects can often be severe, unlike chemotherapy, they are often unpredictable in severity and timing, and they can appear days, months, or even years after the immunotherapy treatment. Here at Clatterbury, we have a immunotherapy toxicity team that it's expert in managing these toxicities, and I'm also a part of this team. And it's very important to have an expert team that is able to detect those toxicities and manage them as promptly as possible to avoid complications. Currently, the immunotherapy toxicity team is in Clatterbridge is a team that involves nurses, involves consultants, fellows. Is quite a multidisciplinary team in that way. We manage toxicities that related to immunotherapy in like immune checkpoint inhibitors, which are the most common immunotherapies. We usually manage those toxicities for all the tumor groups, not just melanoma, but also patients that, for example, with lung cancer that have received immunotherapy and they unfortunately had toxicities. We sometimes manage these patients either outpatiently or in the hospital during an admission. We have here at the Clatterbridge Cancer Center, we have a really large population of patients. The immunotherapy toxicity service is quite centralized, managing all these toxicities, so we do see some of these rare toxicities that happen not very often, sometimes less than 1% of the cases. However, we do see several cases of this every year, so we have quite up-to-date protocols and pathways to manage all these rare but severe toxicities that sometimes happen.